First of all, I would like to thank the organizers for giving me this chance. And so they've given me a simple sort of topic, just on the management. And so I'll go in very short, and hopefully we would have a lot of interactions. So I've been given this solitary kidney. What is important? So when you think of solitary kidney, it can actually be an acquired, like you have a child with Wilms tumor, or a donor. So we're not going to talk about acquired solitary kidney, but we're going to talk today about congenital solitary functional kidney. So if we think about a solitary kidney, congenital, it can either be due to the abrupt non-development during the embryonic phase, and therefore there will be a unilateral renal agenesis. That means one kidney does not develop at all, or it could be because there's some dysplastic tissue, and so the child may have either an aplastic kidney or a multicystic dysplastic kidney, but all these are grouped in congenital single functional kidney because you have only one kidney. So why does this interest us? Is because, like you all know, if you have to do the duty of, like if two of you are there on duty, it's relatively simpler than having only one on duty. So that specific kidney that is there actually has to work harder, and studies have shown actually that this kidney has to work more, hyperfiltration will occur, and therefore the decline in the EGFR, proteinuria and hypertension may be the issues. So why is it important for us to know whether it is unilateral renal agenesis or is it a multicystic dysplastic kidney? This is important because some literature has shown that if you have a unilateral renal agenesis, that has a more faster decline in the EGFR than when you have a multicystic dysplastic kidney. But again, these studies are very small cohorts because it is 1 in 2,000 live births, and then most of them are not detected. So we definitely need more studies on how these patients actually go throughout life. So a scenario can be there that a pregnant woman comes with an ultrasound saying that there's only one kidney. So then what will you do? Like it has been discussed previously also, that if there is an isolated renal anomaly, it is important for us, even if a pregnant mother comes, that we advise them to actually do a level 2 ultrasound to look at all the other organs also, because if there is any other extra renal anomaly, then it is important that even at this point, when the pregnant mother comes antenatally, that you need to involve the geneticist, and most importantly, maybe think of CVS or amniocentesis for further genetic testing. So because the time is short, we'll concentrate more only on the isolated renal congenital single kidney. So if the patient comes to you during pregnancy, and so you will ask for a level 2 ultrasound, and suppose if there are no extra renal abnormalities, there's nothing much to be done, you can counsel the parents. Then, suppose if the child comes either postnatal after being diagnosed with an antenatal single kidney, or incidentally it is detected, then what should you do? The first thing that you have to confirm is that this is actually a congenital solitary functioning kidney. And a few years back, when I was junior resident, we would do all the tests because we know a single kidney can be associated with an ectopic kidney, so we would want to do a scintigraphy to know that the other kidney is not somewhere else, and And because we know that it is associated with PUR in almost a third of the patients, so we would also ask for an MCU. But now, personalized medicine and decreasing the number of tests that you do in a particular patient is so important. And with the data that we have now, at least for now, we can say that if you have a very good ultrasound, when I say an ultrasound here, that means you have to ask for the kidney length, you have to ask for the renal parenchyma, the thickness, the echogenicity, that there are no cysts, the portal medullary junction is normal, the calyces, the ureters are normal, and the urinary bladder. So if you can ensure that the length of the kidney of this particular kidney is normal, if the parenchymal is normal, the porticular medullary junction is normal, there are no cysts in that kidney, the APD is normal, the ureters are normal, and the urinary bladder is normal, there is absolutely no indication to do any other test. If you cannot ensure that a good radiologist is there, then maybe you can think of doing a scintigraphy. So there are many studies actually that show that 100% sensitive when you compare an ultrasound with a scan, and at the most you can miss an ectopic kidney. But suppose if you missed an ectopic kidney by not doing a scan, the management would actually not change. So we're going now more towards what will the patient gain by doing the test versus you do a scintigraphy where you expose the child to radiation, and MCU which is a little bit invasive and also exposed to radiation. So it was told before that if you have a single kidney, it may be the solitary kidney may have a VUR or a PUJ obstruction in a third of them. But if you look at the numbers, the actual VURs which you would need to treat is very less. So this I have taken mainly from the consensus of the pediatric nephrologist, the Italian pediatric nephrologist. But even if you look at the pediatric urologist also, they say that for any intervention you need to do at least 44 MCUs. That means you do 44 MCUs and one would be normal. So the number needed to treat is so major, and the radiation and the invasiveness of it is so much that again and again, I think in most of the talks that we've had, it is personalization. We have these guidelines, but when you have to ask, especially for scintigraphy or for MCU, think how will it help the patient, and in most cases it is not required. So once you know that this is a congenitally single functioning kidney, you would actually want to be very sure that this is normal. Like I said, an ultrasound is the only thing actually that you would need. Because we know that this kidney would actually be functioning more, so we look at proteinuria at the time when we come in contact. MCU and VCUG would be required only if you have some abnormality in the ultrasound. While the guidelines of the European Pediatric Urologist and the European Society of Pediatric Nephrologists say that you do not need to do a plasma creatinine, I myself would say that I actually do. So the pediatric urologists, they have said that refrain from doing a plasma serum creatinine. I do it because for the simple reason that sometimes our radiologists may miss because of the huge numbers that they have to do. And the second thing is that the follow-up of the patients may not be so good, and so if we have an abnormal creatinine at baseline, we would undergo more investigations. But more importantly than all these investigations is something that we actually, when we see a child who comes with a congenital solitary functioning kidney, we are so engrossed into these proteinuria and the serum creatinine that we forget that we should actively be looking every time for any extra-renal malformations. So examination of the patient as a whole is so important because we can see that you would have different syndromes which you can pick up even in simple clinical examination. So how would you manage these children? The use of ACE inhibitors, like we all know, it will prevent proteinuria and help in the hypertension if present. But you should also remember that most of these children you would be seeing during infancy, and giving ACE inhibitors without proteinuria and without hypertension may be detrimental because it decreases the maturity of the kidneys. So you just have to be a little bit more careful when the child is less than 1 year of age. But suppose if they have proteinuria and if they have hypertension, ACE inhibitors are the drug of choice. You should avoid excess protein, but I think in the Indian setting, this does not really fit in so well. But you have to tell them to avoid processed foods because this has been shown that it increases the decline of the EGFR. Obesity is something that increases the risk of the decline, faster decline in the EGFR. So you prevent obesity by doing, having a healthy diet and by doing exercise. So here comes contact sports and the controversies associated with it. But again, if you tell the patient, you should tell that if you do contact sports, there are more chances of a hemorrhage and a stroke rather than having a kidney injury. So the sports association says that you should not prevent, but you should try to tell them that this may add to the risk, though the risk is not so much. And you avoid nephrotoxic drugs and dehydration. In follow-up, suppose if there is a compensatory growth of the kidney, there is nothing much to do. But if there is a decrease in the serum creatinine, proteinuria or hypertension, then you need to follow up. So because it is difficult to see the compensatory growth of the kidney in the ultrasound, I consider all my patients as medium risk, even if they don't have a fat gut. So what we do is that we, the pediatric nephrologist, would see, we would do ultrasound yearly till 3 years of age, and after that every 3 to 5 years. We would do a proteinuria, spot protein creatinine ratio yearly, a BP we will measure yearly, and a serum creatinine we will measure yearly. And because solitary kidney is associated with the Mullerian ducts defect, so we try to do an ultrasound in the adolescents. And if they have any of those high risks, then we follow those. So basically, if you have anybody with a congenital solitary functioning kidney, the main thing is that we have to follow them for life, number one. Number two is that an ultrasound is enough if you have a good radiologist. If you don't have, maybe you can add the serum creatinine. You have to look at proteinuria and the BP of the child. And the main thing is that you just tell the patient to, live a healthy lifestyle, avoid nephrotoxic drugs, avoid dehydration, prevent obesity, and I think that would be the gist of it. Thank you.